Lower respiratory tract infections are the leading infectious cause of death for children globally. For the clinician, every struggling patient is a high-stakes puzzle. Take a typical 6-month-old infant. They present with tachypnea, subcostal retractions, hypoxemia, and a fever. On the surface, these symptoms are ambiguous. They could signal acute bronchiolitis or community-acquired pneumonia, two diseases that require fundamentally opposite clinical interventions. Distinguishing them requires us to move past an over-reliance on standard imaging. We have to map the exact point where these diseases diverge at the microscopic level. Modern medicine has come far, but we shouldn't forget the historical mortality rates of pneumonia and respiratory viruses. Vaccines and antibiotics drove a 97% decline in pediatric pneumonia mortality during the 20th century, yet the differential diagnosis remains a trap for practitioners today. Despite these public health victories, the microscopic battleground of the infant lung still demands a precise, non-radiographic diagnostic framework. To understand the divergence, we divide the lower respiratory tract, bronchiolar level on the left, alveolar on the right. In bronchiolitis, RSV invades the epithelium, causing necrosis and mucus plugging, physically narrowing these tiny tubes. Community-acquired pneumonia targets the deeper alveolar level. An initial viral injury destabilizes the resident microbial community, allowing Streptococcus pneumonia to colonize. The result is localized edema and lobar consolidation as exudate replaces air. This creates a very unique clinical danger. Because complete obstruction eliminates the airflow turbulence that causes wheezing, a sudden silence in a distressed infant is a sign of nearly complete bronchiolar blockage. One patient suffers from obstructive debris in the airways, the other from deep inflammation in the air sacs. Two different mechanical failures, appearing identical on the surface. This is the standard clinical reflex, ordering a chest radiograph to find an answer. But in the pediatric airway, the image is often a lie. This is the atelectasis trap. Viral bronchiolitis causes lung collapse that perfectly mimics bacterial consolidation. This ambiguity is why guidelines recommend against routine outpatient imaging. It often just encourages unnecessary antibiotic use. We must dismantle other common tools. Sputum cultures are useless in infants, and urinary antigens give false positives. Instead, the clinician must rely on the physical exam, looking for the focal findings of pneumonia, like dullness on percussion, versus the diffuse wheezing of bronchiolitis. While most labs are unhelpful, a white blood cell count between 15,000 and 40,000 with a polymorphonuclear predominance strongly signals a bacterial cause. In the pediatric airway, standard imaging and rapid tests often confound rather than clarify. A structured physical examination that identifies focal versus diffuse signs, combined with local epidemiology, is the superior diagnostic path. Once the clinical diagnosis is set, the intervention paths for bronchiolitis and pneumonia diverge completely. In the bronchiolitis arm, care is strictly supportive, prioritizing hydration and oxygenation. Pharmacological agents prove ineffective here. Because the obstruction is physical debris rather than muscle spasms, albuterol and steroids provide no benefit. The pneumonia arm requires rapid, age-stratified antimicrobial therapy. For children under 4 years, S. pneumoniae is the primary target. High-dose amoxicillin is the first-line choice. In patients over age 5, the etiology shifts toward atypical pathogens like Mycoplasma pneumoniae. This requires a shift to macrolide antibiotics like azithromycin. Successful intervention isn't about identifying a specific pathogen in real time. It's about executing a matrix of age, epidemiology, and pathophysiological probability. Every diagnosis starts a 72-hour clock. An uncomplicated bacterial pneumonia should show clear clinical improvement within that window. If a patient fails to improve, the clinician must immediately look for complications like pleural effusions, empyema, or underlying anatomical defects. Regardless of the initial diagnosis, signs like a toxic appearance, hypoxemia, or severe dehydration are absolute indications for hospitalization. We must be especially vigilant with premature infants. Those at a post-conceptual age of less than 48 weeks are at the highest risk for sudden apneic events. The initial diagnosis sets the course, but the patient's physiological response in those first 3 days is what ultimately confirms the pathophysiology. While diagnosing these infections is critical, the true goal of pediatric medicine is to prevent them from occurring in the first place. The impact of immunization is undeniable. The introduction of pneumococcal conjugate vaccines drove an immediate 35% decrease in pneumonia hospitalizations. Differentiating viral atelectasis from bacterial consolidation is a difficult clinical trap. For high-risk infants, we can also use palivizumab, a monoclonal antibody that shields the airway from severe RSV bronchiolitis. But targeted immunology is systematically dismantling the threat before it ever reaches the infant airway.